You graduated, you got licensed, and then a client with chronic illness walks right into your office and you're left not knowing what to do. And 76% of your clients have at least one chronic illness. And what I know about that is they're exhausted and they're so tired of being dismissed. And they need you to know what you're doing. That's exactly why the Chronic Illness Therapist Conference exists. 2 days of real, evidence-based, trauma-informed training built especially for clinicians like you already doing this work. You'll leave knowing how to properly assess what your client actually needs, not what you think they need or they think they need. You'll understand the foundations of working with medical trauma and complex PTSD related to ongoing healthcare struggles. And you'll finally have a framework for all the grief and identity shifts that come along with living with a chronic condition, all without accidentally reinforcing cure myths. Join us March 6th and 7th, virtually or Atlanta, totally up to you, for 13 CEs for physical therapists, counselors, social workers, and rehab counselors. Our clients can't wait for us to figure this out on our own, so we hope you'll join us. Registration is below. The Chronic Illness Therapist podcast is meant to be a place where people with chronic illnesses can come to feel heard, seen, and safe while listening to mental health therapists and other medical professionals talk about the realities of treating difficult conditions. This might be a new concept for you, one in which you never have to worry about someone inferring that it's all in your head. We dive deep into the human side of treating complex medical conditions and help you find professionals that leave you feeling hopeful for the future. I hope you love what you learned here, and please consider leaving a review or sharing this podcast with someone you love. This podcast is meant for educational purposes only. For specific questions related to your unique circumstances, please contact a licensed medical professional in your state of residence. Dr. Heather Olivier is a licensed professional counselor and supervisor specializing in working with neurodivergent clients and psychosomatic presentations of traumatic loss. In addition to owning her own private practice, Olivier Counseling and Consulting, she's an assistant professor of counseling at Southeastern Louisiana University with a focus on creating inclusive curriculum design for neurodivergent students and faculty. Dr. Olivier's research regarding perinatal loss has received state and national recognition, and she's the first person in her field to ever receive the 2 highest national research awards given by the National Board for Certified Counselors and the Association for Counselor Education and Supervision. Heather regularly presents nationally and internationally to interdisciplinary audiences on neurodiversity, patient and practitioner wellness, and cultural stigma impacting trauma. Well, thank you, Heather, for being here. Anybody who just heard your bio can automatically know why we invited you to our conference, because the whole conference is going to be around interdisciplinary care for chronic pain and chronic illness. So thank you again for being here.
And thanks for having me.
Yes. Can we start first by you can tell the audience what specifically drew you to the intersection of neurodivergence and chronic illness? You could maybe weave in some of the perinatal work that you do as well, but what drew you to this work and how did you get into it?
Yeah, you actually hit the nail on the head with starting with the perinatal piece, because a lot of, especially researchers and academics in my field, have wondered why, after doing all of this research and collecting all this data and those awards that you mentioned, that was all based on perinatal loss research. So I have gotten questions regarding why now would you switch to another specialty? But for me, they are very intertwined. So a lot of the perinatal loss clients I was seeing who are experiencing maybe infertility, multiple miscarriages, and other losses, were then having to go get genetic testing. And I started seeing this overlap between these losses and people who are neurodivergent, or maybe had what is called the MTHFR gene that was only discovered once they were experiencing infertility, which is also tied to, there's a lot of correlation between that gene and being neurodivergent. So they were learning that, and then also putting together pieces about ADHD possibly, or autism. So I saw a lot of overlap there, which really made me curious. And then also just my own exploration, like many neurodivergent people who end up specializing in this area, likely because we've had to do some self-discovery and we realized, wait, nobody's talking about this. So that's really what drew me to this field. And the perinatal loss research really was the catalyst for me landing here.
Yeah. And you practice something called relational-cultural theory, right? Or is
Yes.
that tell me a little bit more about that.
Okay, so that's one of my favorite. All my students would be so excited talking about this, but it is a theoretical orientation that is used in a lot of different fields. But counseling, it's something that we teach in counseling. And it's newer. It's a product and a wave of the feminist movement, but it's essentially based on the fact that as human beings, we're built for connection. And if we go back, thinking neurologically, that's what our mirror neurons are for. And so, because we're meant to be in connection with others, it works so perfectly using relational cultural theory with individuals who have chronic illnesses and also neurodivergent individuals because connection is really this barrier they often face, even going to medical appointments or finding counselors who will validate their experience. Connection is at the core of that experience. And we know that, the research tells us that the therapeutic alliance itself is the biggest catalyst for change. So we can have all these beautiful tools, but if the relationship isn't there, none of them are going to work. So relational cultural theory is something I'm very passionate about, especially working with neurodivergent individuals.
What are some of the most common overlaps maybe you're seeing right now in diagnoses, like specific neurodivergent diagnoses as well as physical conditions? And then maybe we can also weave in that relational piece again of why it's so important, not only like the communal kind of person to person relational aspect, but I'm even thinking about the relationship between the diagnoses.
Mm, yes, I love that question. The first thing that comes to mind um, is the misdiagnosis. That's my initially what came to mind. I have a
Yeah,
lot of clients, and
definitely.
yeah, it was interesting because around the same time, I got this influx of clients, were females, and many of them being misdiagnosed as either bipolar or borderline. And part of the way that I experience my um, intuitiveness, but also just my sensory system and with synesthesia is I will feel different diagnoses in different parts of my body. Um, I tell students about that just to be for them to learn their systems, but I don't teach them. Here's the diagnostic tool that but it was these clients were coming in and I saw the confusion on their faces. They were coming in with these terrible physical reactions um, that if the chemicals in their brains were responding to an accurate medication, they would not be experiencing. And what I was seeing was women who have ADHD and also have PMDD, the premenstrual dysphoric disorder. So those 3 to 5 days before the cycle starts, it they were having a major dip in emotions, and that's where maybe fights were happening in relationships or decision making that maybe looked similar to mania was coming up, but it was only during that time. So then we were able to explore those diagnoses, and with those being more accurate, really this therapeutic process was then they were able to take that outside of the therapy space and have that for themselves to really validate their experience, and take on a label that they felt was accurate.
Yeah,
Yeah.
I think, I mean, I've definitely seen that where clients their diagnosis is just, it doesn't quite fit like what their lived experience is, or it really, really fits like something like PMDD because that experience, goes along with all these other diagnoses as well, but they haven't gotten like the answer to it. And so I think what I see a lot in my practice is a lot of a desire to find the root cause, which brings us into usually like functional medicine. And
I will say like there can be really, really helpful and life changing, as well as like sometimes people just chase more rabbit holes and kind of
Right.
go down these root cause like rabbit holes that don't actually give them a lot of relief. So it can be really hit or miss there. But what you're speaking to is like just this intuitive knowing if something is maybe not right, or it's not, the diagnosis isn't quite fitting the experience. Is that right?
Yes. Yes. And you know, with that overlap, kind of going back to your question of, you know, what I'm seeing with that overlap is primarily in women, and I'm thinking kind of more with the ADHD, so many women who are, or individuals socialized as women, so female clients who come in and they're realizing in their late 20s, 30s, 40s, that what they were experiencing didn't look like the textbook scenario of when they learned about ADHD in the 80s and 90s. And so, you know, and that's why with the DSM shifting from ADD to just ADHD with three subtypes, that gender piece was very influential with that change in diagnosis, because we know that women primarily, their hyperactivity is internal. So these were the students in class when they were little who were very still, very quote unquote well behaved. But they're the ones who were likely experiencing eating disorders, anxiety, all the internal things that also they're dealing with as adults that have turned into chronic illnesses as well. So I just think
Yeah.
it's fascinating, and fascinating in a way that is a disservice, but that how even the misdiagnosis has lended itself to so many late onset or chronic illnesses as adults.
Yeah, I think this is like a really tricky conversation because and you correct me if I'm wrong, I think science can't like prove or disprove either way of how, like, we have a lot of science around how stress and trauma, creates a cascade of biological events in the body, like increased, prolonged heightened cortisol and things like that that can then cause chronic illnesses down the road. But what's tricky about it is like, why does one person, maybe two people go through the same experience and one will develop a chronic illness and one wouldn't? And then that's where I think it's just, there's just some parts that are heritable, genetic, that you cannot control no matter how stress free your life is. So I think that's why there's so much discourse around this right now, because there aren't very clear answers. But I would love to hear your perspective on that.
I completely agree. Because even the term autism spectrum, we know that it's not this dichotomous spectrum, that it's more of like a sphere. And so even the language, which is also a big part of relational cultural theory, is understanding the subjective definition that we all hold with each word. And that's a sidebar concept of symbolic interactionism is, with our clients, we can't assume that we define things the same as them. Even if, we have six people in a row that day who are saying they have anxiety, it's going to look different. So even with our verbiage of autism spectrum, it's not, that comes up a lot where people say, even when I disclose my autism diagnosis, people will say, that doesn't make sense. It's like, oh, okay. I didn't know you lived in my head or my body, but thank you for that feedback.
Exactly.
I'm better.
Yeah.
But it,
We have such a
so
narrow view of what autism looks like. And could we do a little sidebar on maybe like the discourse right now between, some people are really, the folks, especially parents of children with autistic children who maybe like they need the level 3 supports. And so they're often nonverbal, lots of meltdowns and throughout the day, and need 24/7 care. And so right now the discourse is like, we're putting people who are able to like go to school, hold a job, things like that in the same bucket as folks who can't. And people are really struggling with that. I'm just curious if you want to speak to that at all.
Absolutely. Yes. I think two things come to mind. One, I think it's important for whatever field we're in, for if diagnosis is even touched upon in that field, the front line from my perspective is the educators. So we need to be integrating, even if it doesn't say, check, like something that I've been discussing with a colleague of mine a lot recently is, okay, even though each academic space has check boxes, even for diversity, we shouldn't just be checking the box. It should be integrated even with case studies, for example. So what you mentioned about, the differences in how it impacts their lives and that level of distress, that's something that I use in a lot of case studies, even in my group class, for example, when I'm teaching them how to determine what sort of participants, what sort of group members would be in there. I use that example. Actually, that's funny that you say that because I'll say, if I were to say I am starting a group for autistic individuals who are unemployed, it would be critical that I differentiate between the fact that, or between participants who are unemployed by choice or unemployed because of the level of care, um, which keeps them from being employed full time. Because knowing that that will not be therapeutic to be in that space together, and could actually be very dismissive, and it really could be harmful for many people. Um,
Thank you. Yeah. And maybe we can even talk a little bit then about how it ends up being similar, how it ends up being similar. Like that is the same diagnosis despite needing different levels of care. And I know from my own understanding what that looks and feels like is, for example, if we're going to use a meltdown and a child who is nonverbal is melting down and you don't know why, or as a parent, you might know why. You might know that they're hungry or that they didn't like the tag on their shirt or the different things that might set an autistic child off into that, when they can't verbalize what's happening, that, but for us, I think, when you, when you are more level one and you are, again, you're able to work or you're able to be in society without really, people wouldn't know unless you told them. One of the experiences that comes up a lot in my own sessions is like, if I get confused or overstimulated or, which is a normal human experience. I think everybody, regardless of neurodivergence, like gets overstimulated if you have enough stimuli in the environment. But when that happens, the internal feeling is like that of a meltdown. We just might be able to not fall on the floor and start screaming and flailing. We might be able to hold that in, but then what does that do to us physically and emotionally that we have to then go home and like decompress from that?
I love this question because that actually touches on that second piece I was thinking about, which is for individuals who are at a level one need of care. I think it's important that we verbalize our internal experience. Because again, if we're even thinking about even an ADHD diagnosis, that or the hyperactivity being internal, it's, you know, there wouldn't be that differentiation now if no one was talking about it. So I think for autistic individuals who are at that level one need of care, it's important. For example, I was telling my mom, so I was diagnosed with ADHD in college, and then was diagnosed with autism in 2023, fall of 2023. It was right when I started as a professor as well. So that, of course, brought in the imposter syndrome to the 10th hour. But I was telling my mom this past week something to the effect of, I wonder what most people experience when they receive a text. She was kind of like, what? And I thought, every time I get a text, I assume I did something wrong or someone's mad at me. And I was like, every every morning, I was like, she's like, what? I was like, yeah. I mean, I was like, that's my baseline. And I, was always like, a straight A student, but it's not because I always got in trouble. It just is always my baseline. And I don't talk about it. And I realized that was, she said, I think my family calls me H. Like, H, I never realized you experienced that. She's like, I'm so sorry. But just now I'm realizing the things I need to verbalize, even like with friendships. This has happened many times where people will say, I've had very awkward experiences where people will say, oh, yeah, since we're friends. And in my head, I'll think, oh, I didn't, like, I'm excited, but I'll think, I didn't know we were friends. And it's because I met them in a and even Victoria, who's putting on the conference as well, is one of the things that she will say to me oftentimes when I get a text, many times at conferences. They'll say, hey, we're hanging out at this place. And for me, I think, oh, well, that's cool, but they didn't invite me. And she will say, Heather, they sent you that text because they want you to attend. I'm like, but they didn't invite me. So and I know those are light examples, but that happened in October of this life. So it is still something that I live with every day. And last random example, but I think these are relatable is I remember someone in a faculty meeting one time complimented my shoes. And my first thought was, I didn't know we were allowed to do that. And I just something about being able to talk about clothes in a workspace. So these are the things that now the reason why has been so validating for me to receive that diagnosis is I'm able to see other people's experiences, and it is so helpful to know, oh wait, other people think those things too or go through these processes. And so I say it kind of going back to your question about, what's the connectedness within that, and what I'm hearing is like, what is a relationship between groups and then also within groups. So I would say it's important to, even if people are quote unquote functioning well as being perceived by others, I think it's important for us, if we are able to describe our experiences, even describing our experiences of breaks in communication or how it takes longer to form relationships because we are misunderstood or misperceived. That by us describing ours, I genuinely feel it lessens the gap between like the misunderstanding of the diagnosis as a whole. And that's just my opinion. I don't know what you think.
Yeah, and I think that's why the lived experience is like a lot of us are disclosing more and like talking about it as openly as we are on podcasts and social media and whatnot, because the examples we see on movies and TV and media is usually neurotypical, and this just gives such a good model for people to see themselves in it so that they don't feel so alone in it. And ironically, that usually helps people feel a lot less stressed to be themselves, which in my experience, especially at that level, well, and also I'm not diagnosed. I think I understand the experience a lot. But in my experience, it's that at that level, oh shoot, I just totally lost my train of thought as I was giving that little sidebar, but that's okay. Yeah, we just really need the lived experience modeled so that the stress levels can be reduced. And oh, that's what I was gonna say. As you feel less stress around it and you are more yourself, I find that you actually are more like socially accepted as well. I don't know if that's the right way to put it, but not that we want to like do everything to be socially accepted. It's almost, it's this kind of backwards, like when you stop Carl Rogers, when you accept yourself as you are, then you can change, or then you can be as you need to be, really, and you are more accepted, I think. People really like confidence.
Yes. So, okay, that is a perfect like kind of way to weave in RCT here as well, because they reference Rogers and they say if Rogerian therapy is person centered, RCT would be relationship centered. And so RCT posits that in the same way that Rogers said, you know, we have to have unconditional positive regard, RCT says the way that the most effective part about having unconditional positive regard for our clients is that then our clients are able to have unconditional positive self regard. And so, like, the relationship, it's not just a output, it's more of a like reciprocity there. And so I 1,000% agree that for me, even, I have something in my syllabus now that says, you know, it's just a brief blurb of, you know, as a neurodivergent individual, it's under the class etiquette piece, um, where it's something to the effect of, you know, I'm not asking you to not have your phones out because I'm trying to be authoritarian. It's I will be distracted. And so, you know, for this to be an inclusive space for all of us, and for me to be my most effective self, like these are my requests just based on the way that I process the world. Um, and I've had
Yeah, the
students,
request is in that relational framework of like, this is simply a need that I have. And when you live in a society with others, we want to respect each other's needs. And I know a lot of folks, neurodivergent folks, do a lot better when they understand the why behind an ask. Which is
yeah,
interesting because actually, not even in a neurodivergent lens, but we know that authoritative, which is not authoritarian, authoritative is that like, here, I have a request of you and I have an expectation of you, but I will explain why. It's not just do as I say because I said so. That is
right.
the most effective form of parenting, whether you're neurodivergent or not. So it's just an interesting, I think that's just an interesting tidbit.
Yeah. Yeah. I had never put those pieces together, but yes, I'm literally thinking, okay, put that in the file for parenting. Um,
Yeah,
they,
totally. Yeah.
and I,
That was really eye opening for me of like, yeah, go ahead.
And I think it you know, our jobs as clinicians, in my opinion, is really to so much of it is modeling for our clients as well. And even being able to say, so I moved to an office space where there are options on places to sit. And sometimes people come in and just sit on the floor if that's what they need to do, or fix a cup of coffee if they need like a stem of like holding. They might not ever drink it. They might just clutch it the whole time. Um, but modeling asking for our needs and that being okay and not being selfish on where now I've had students who will say, like one student who I have discussed in presentations, and she's given me permission to say this, that um, at the end of the semester, one semester, she was doing her final presentation and asked, uh, she said, she disclosed, as somebody with dyslexia, I'm going to request that one of my classmates read this case study. And I just thought it was a beautiful example of how to create an accommodation for herself in a way that was appropriate, as for her needs, but also and I thought it was um, therapeutic and clinical within that space. So it just something about being able to kind of going back to what you were mentioning. I think discussing our diagnoses and how we individually are impacted by them. Um, it really does break down those barriers. So even, you know, a lot of those social and communication barriers that we experience, even like texting, because a lot of my processing um, takes place with my sensory system. If somebody's not in front of me, if I get a text or an email, I can't feel what they mean. So email can be very, and I know that I get the rap of she's bad at email. It takes me a lot longer to process what is being asked because I can't feel that. So I'll do
Yeah,
things like voice memos or things like that.
that makes sense. Yeah. Yeah. And I think there's multiple ways to like work around that. One of which is the accommodation of, obviously we can't send voice memos through email, but it would be nice actually if that feature was in there. Um, But we are moving now into that. The second objective you're going to be talking about at the conference is about barriers faced by neurodivergent and chronically ill therapists that impact the therapeutic process. So part of it is, yes, this maybe need for a different communication medium than what's available or just what's normalized. You know, sometimes the accommodation is available, but because it's not normalized, then it becomes a barrier to having access to that. What are some of the other barriers that people start to that really impede the therapeutic relationship, whether that's in therapy or physical therapy or any allied health professional?
Yeah. I'll start with the example of like how I've been fidgeting a lot, and my legs are crossed. So as somebody who uh has POTS and MCAS, and that's why I loved Dr. Pepper's podcast from last on, POTS, MCAS, hypermobility. So with hypermobility, I want to have my legs crossed. But in school, we're taught that's not therapeutic. So I think it's important for clinicians in many different fields to understand if you're neurodivergent and if you have a chronic illness, which we know there's so much overlap there with those experiences. If you aren't making those accommodations for yourself and you're going based off of, um, again, knowing that, like you said, knowing I could make this accommodation, but it's not socially acceptable. If we go back to even our code of ethics, okay, even if something's not socially acceptable, I need to be worried about what's most therapeutic and what will not cause any harm, what will not impede upon this process. And so if I'm worried that I have blood pooling at my feet and I'm thinking I'm going to be dizzy when I stand up, um, then that I just checked out of the session. Um, or if I'm experiencing pain that I know could be adjusted if I just move a little bit, even if the seating looks awkward, knowing, will I be more present? And if so, that accommodation isn't just for me, it is for the process overall, because I explain it like if I can check that off in my for my central nervous system to I'm acknowledging the threat that it is alarming me of. I'm checking that box and I'm removing it from that list so that now the biggest threat is what I am placing as the threat of this person is in distress. How can I be with them right now? Um, so I think
That's my exact
attunement
experience.
really,
Yeah, I mean, I do mostly virtual work, and even like I can kind of show you right now what this usually looks like. But my clients know, like I'll move around, like I'll bring my chair. My chair's back here. I was just standing with you. I'm still talking as I'm doing this. They know I'm paying attention to them. I'll bring my desk down for people who are watching the video. You can actually see how this process works. And then yeah, I might just adjust my desk a little bit, and we're just continuing the conversation as I am now more comfortable because I can think more clearly. Because if I had stayed
right.
standing, like my low back is starting to bother me, I might start thinking about it. Whereas now I could just sit, and I don't know if this is the ADHD or the chronic pain or whatever else is going on, but I don't really care what the diagnosis is at the moment. All I know is that my nervous system needs to sit right now, and then it might need to stand up again in 10 minutes from now. So I've had a couple of clients, like, they might pause and think like, okay, does she need me to pause? Maybe she's not paying attention anymore. As soon as
Yeah.
I explain it that very first time, like it's never an issue again.
100%. Yeah. I'm literally, so I have on heels, and trousers, but my legs are crossed. But and yeah, that constant, like, I can't tell you how many times I've thought, especially when you're on like a virtual meeting or something like that, when you can only see the top, I'm thinking, okay, I need to remember, and then constantly going through that process of, why do I hunch over? Why are these, in all these processes, if we are hyper aware of them, that's been our focus. And again, going back to, for me, it really is the relational piece. By us saying that at the beginning, I point that out in my intake sessions, and I'll say, by the way, even with eye contact, I'll say, if I am not looking straight at you, or if I have a very flat aspect, it's not because I'm disinterested. It's probably because I am so interested that that's not even on my mind to mask in that moment or attempt to stare into your soul. Um, and because it's more about, and once they know that, their central nervous system will no longer see that as a threat. So even that uh, break in communication where people who are neurotypical, or maybe even people again who have a different level of autism or even ADHD, they experience too. So even within or between neurodivergent people, if you have different experiences of those communication pieces, just removing that barrier, it's again that checklist for their nervous systems to say, okay, that's just our process, which is good. As a quick side note, I always love to add this part about the eye contact. Um, and I have talked to so many autistic individuals who experience the same thing where um, a lot of people will say, oh, they just can't make eye contact. So it's awkward. But for me, I know if I lock into somebody's eyes, I get my mirror neurons are so attuned that I get too much information. And then I can't unknow it because the mirror
Yeah.
neurons there. And it can feel intrusive, almost like they didn't give me permission to feel whatever they're feeling right now. So that's another, I always like to add that for my students. Like, by the way, this is really what the experience is for many autistic individuals.
Yeah, I love just educating on that experience. That I have that same exact experience. It for the way that I've explained it is just I get overstimulated just by like looking at someone's eyes, and I will lose my train of thought. So again, it's not even about like just for the sake of comfort. It's also about efficacy and being able to do my job.
Yeah.
And being able to just hold a conversation. The eye contact, like
Right.
I start to think too much about what they're thinking or maybe what they're feeling, or I like need to look away. I mean, it's so funny. Like, yeah, I've had so many experiences. I feel like it's been more recently, like an uptick in this. Maybe I've just been doing more in-person stuff lately, but I tend to look to the left when I'm trying to really concentrate on what I'm saying and not concentrate, not feel or think about what the person in front of me is saying. And like sometimes I'll find people like moving into my left, like into that visual field, like they're trying to like catch my eye contact again. And I'm like, oh man, I don't know how to tell you that this is actually me better paying attention to you, but that is like, can we just not, does this have to be, it doesn't have to be awkward. It could just be normalized.
Right. Right. And that's what I want to say. Like, this does not impact anyone's life whatsoever. This is just a social norm. Um, yeah.
Yeah.
Well, and with the, what's often not brought up that I think my, so one way that I experience autism is the pattern recognition, and even seeing like, okay, especially in research, where it's, okay, I'm seeing this. I bet this is about to be a really big thing. And then the ADHD, however, is the part that's like, okay, now I'm bored. It's not great. But, but with that, so I think a wave of research that we'll see in the next couple of years will be on, the experience of synesthesia and chronic illness. Um, because I know from, huh?
Can you explain that?
Sure, yeah. And so with synesthesia, for a lot of people I know that aren't familiar with it, it quite literally means mixing of the senses. And so all of us as human beings, we start with the baseline of synesthesia. So that's where we get verbiage like sharp cheese. You know, we know that cheese isn't actually sharp, but everyone knows what that means. Or warm tones and cool tone, so it's part of our vernacular and people know those things. But for neurodivergent individuals, it's typically heightened. Um, and so I know for me, and that's where a lot of the communication barriers that occur, um, accommodations that a lot of individuals make unknowingly, and I've found this out with myself and have since asked many people, um, have been through their synesthesia, which is why it was not caught. So I would know what someone felt not based on the words that they were saying, but the colors I saw around them. And or I let's say, for example, a client whose personality is blue, like they always see blue around them, typically nurses, helping professions, things like that. One day walked in and they had yellow on them. And I thought, okay, they're really overthinking something right now and it's impacting their ability to be present with people. So I don't tell them, hey, you're usually blue, but today you're yellow. But I was just able to, but I didn't know that people didn't experience that. But with many people and there's so many different forms of synesthesia, even, uh, synesthesia is the reason that music is even a thing, for us to hear something and then experience an emotion. There's two separate sensory systems. And so, um, but one of the forms that I have is mirror touch. So when someone else is feeling pain, I'll feel it in my body. Um, Typically more in movies, which is interesting. I'm not sure why, but if I am very attuned to people, especially in session, um, an accommodation I had to make for myself was I can't see people who've experienced trauma, like physical trauma. I can't see them back to back. I can only, once I realized that my body was experiencing a lot of the stuff they were describing, or if they were currently feeling that pain. So even that awareness of this distress I'm experiencing is real. That's another thing that um, Dr. Peppers in her podcast, she said, even just validating, I believe you, this is real. That is for so many clinicians and practitioners, just pointing out you don't have to push through. You can implement breaks, or you can, when your body is feeling distress, that's real. That distress is real.
Yeah, yes. And, for someone listening who's like, I don't see colors, or I don't, in that way, or I don't like I don't have a inner experience that kind of even tells me like what you're describing. I think the main message is what you just said. Like, if there's discomfort, if there's distress, it's not about, there might be frustration around not knowing exactly what is happening or why it's happening. But when we can't figure that out right away, we, in my opinion, like need to push that aside for a moment and just be with what is, and the answer will come, whether that's colors or sensations or memories or thoughts or images. Um, and you practice brain spotting. I'm really interested to know, especially because whenever I like do the eye contact thing over to the left, I'm like, I wonder what this means in brain spotting. 'Cause I'm not, but can you share a little bit about brain spotting and how you start to help clients with that?
Sure, yeah. So I got into brain spotting as a client after my first son passed away. And which is important because that's when I decided to go into perinatal loss research and working with people who'd experienced that same thing, because I wanted to find a clinician who had experienced it, primarily because I wanted to be able to say things like, I want to be with my baby and them know that's a maternal instinct and it that's not a suicide threat, So I wanted even to be able to describe things. And it was I at that time, the perinatal specialists are very common now. This was almost 10 years ago, and it was not. Um, I couldn't find anyone. Thankfully, I found an incredible trauma specialist who introduced me to brain spotting. It's Emily Moe's Fontenot, who's the president of the Southeast Brain Spotting Institute. Um, and so that worked for me. Brain spotting, this is a very not a great not a great definition, but for very quickly, if we think about the brain, that trauma is really stored in that inner brain. And so, but by the time that we're thinking about it in our prefrontal cortex, um, that's where we're going through the decision making of, well, why am I anxious? As I walk through this store and I hear a baby crying, I'm, I shouldn't be. I come to the store all the time. Nothing's wrong. Something's wrong with me. I must have anxiety. So we think ourselves out of it and it stays as two separate systems. Well, brain spotting, um, because our eyes typically find spots, of really where they store. It's almost like the file for this specific event is stored in the same place as this spot or this spot over here. Um, and so if you notice, even whenever you talk to people, like if I was describing to you, Destiny on the way here, I almost got into a car accident. If I'm maintaining eye contact, but then every time I describe the experience or my feelings of it, maybe I look to the left and up and I'll say, but God, I was so scared and the person was doing this, blah, blah, blah. And then I would come back to you. Because we can't maintain that distress for too long. And so when we do things like bleep or shift our eye contact, it is like our brain saying, whoa, 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 we can't process that right now. This isn't the time or the place. But we get so good at it that we typically never process it unless we stay in that spot. So with that, it really is the way that brain spotting teachers will describe it is it's like you're trying to get in the house, but you can't go through the front door. So it's almost like how else can you maintain that? And then it essentially lets your brain do what it's designed to do. And it refiles that traumatic event or whatever else occurred. It refiles it as this happened and it was an experience, but this isn't happening right now. This isn't, I don't have to respond to that as a current distress or a current event that I need to respond to.
It makes me think that it's like all of the kind of trauma therapies, our goal is to help clients process a traumatic memory or feeling. It doesn't even have to be some like actual car accident memory or just like the feeling of shame, like intense shame,
Yes.
maybe within social situations. Like, I'm not saying that that's what my experience is and why I look to the left so much, but I will think about it after this episode. Like, what am I feeling when I look over there? And just like processing and bringing awareness to the piece that you don't want to feel, and then feeling that in a safe container, which could be the therapy room or maybe on a hike or like somewhere where you feel safe.
Yes. And the reason I did brain spotting and I saw how much it just changed my life. Like I would go from one of the ways that I experienced the PTSD was through nightmares. So it was like every time I went to a brain spotting session, I would feel immediate alleviation in those symptoms. So I got trained in brain spotting level 1, level 2. And when I describe it to clients, I think what's important is that I'm able to say, this isn't something random. Like I believe in this. Like it personally has changed my life. But also so when I initially did that, I didn't know how effective it would be with neurodivergent clients as well. But if we think about even the interoceptive awareness and how we are so good at just shutting off our bodies, um, or not paying attention to our physical sensations, what brain spotting does is how you're describing, what's my body feeling right now? That's where you would determine what spot to land in is when you start to feel a sensation. So it also now I use it in ways to help people bridge what am I feeling? What am I experiencing? And then what's my body feeling? So it helps also with that.
Yeah, I love that. Can you give a couple more examples from a chronic illness lens of what that might look like with bringing awareness into the body or something else like related to living with chronic pain or chronic illness?
Absolutely. Excuse me. So for people with chronic illnesses, it might be um, how you, had a student recently doing a project on chronic illness, but wanted to look at the embarrassment, the subjective experience of embarrassment and how that shows up in social settings, even. So whether it is the emotional uh, ripple effect of the experience itself, or if it is actually the physical experience, a lot of people are able to, while it feels separate, very separate, like here's my physical feeling and here's the emotional impact. Brain spotting has been very helpful in weaving those together as um, not necessarily one experience, but something about validation of the physical experience itself alleviates the emotional distress because they can often feel so separate. Like, because if we think about even embarrassment or shame, humiliation, um, those feel the inherent experience of those words are more so about this is a me thing. I need to not do this. But if we're able to say this is part of your body, this is part of your system, um, once we're able to really shed light on what exactly their subjective experience is of whether it's a condition or very physical pain, it it really changes the verbiage and the physical, excuse me, the emotional experience in other settings. Um, and really, because that's where, uh, uh, you know, and I don't know what your experience is with your clients, but I know for a lot of individuals who are coming in with chronic illnesses and chronic pain and just things that feel very internal, especially those invisible um, illnesses, it can be that much more debilitating to really recognize what's going on. There's almost like this recognition something's wrong, but most of their time is spent in a space of avoidance. Like, I can't think about this because I have to do these other things. Or if I focus on this in a social setting, if I tell them how I really am when they ask, how are you? Um, then it's going to bring down the mood. So we're worried about the emotional, the psychological, the time. So for a lot of clients that I see, there is really a lot of numbness. Even though they feel the pain, there's also this detached numbness from the relationship with their body, because then that would mean fully feeling the pain. Um, and so instead of going from a framework of how do we, how do you manage yourself, it shifts into how do I want to show up in spaces? Um, what does discomfort look like? What does I, I I like to phrase it like if our brains are and our central nervous systems are filing cabinet, there's a drawer that says comfortable, there's one that says uncomfortable but tolerable, and one that's uncomfortable and intolerable. And so, do we even know what's in that top drawer? We know that there are files in there, but what do they say? And so it's really about creating a sense of safety and even the idea of understanding their bodies. I feel like we never have that space.
That was perfectly stated. Yeah. Yes, because I was thinking about maybe even people who feel like they're already on high alert of every sensation in their body, and it's not that they're shut off from it. Maybe they might even be thinking that they're like too turned on to certain sensations in their body, and they want to learn how to like quiet that. But I think I would imagine, tell me if I'm on the right track here, that there's still an avoidance there around something. And so brain spotting can help us figure out what that avoidance is, which might help actually calm down some of that overactive response.
Absolutely. Yes. And because that's what is so interesting. I'm so glad you pointed that out because so many people do have that heightened attunement of, oh, I feel this, I feel this. Like even as we were talking earlier, how we're talking about our position, I was thinking my shoulder and then my leg and then but then even being able to, for us to understand, okay, when I have hypermobility, these things fall under that. And then like deep diving into how that impacts me, it really that um chasm between this is how my body feels and this is how I'm allowed to feel. Like, it that's where it's like that numbness is. And so, and I think in that space, because we want connection, we want to be with other people, we're communal beings. Um, this is for a lot of individuals, and I don't want to say that this is like a blanket statement but I know for so many individuals with chronic illnesses that this is where anxiety lies, this is where depression lies, because it's I feel this, and there's also the expectation to be here, and in this space, it's brutal.
I agree. I think that's a perfect explanation. So we've really been talking about the lived experience, strategies and accommodations for an inclusive therapeutic experience. Because again, if you're comfortable as the clinician, that helps you figure out and be more present with your client, and it's just more effective for everyone. And then helping them figure out their accommodations and what they need internally, externally, all of the above helps them be more honest and raw in therapy, which is, one of the main ways that we're going to elicit change. And then we've also talked about some, strategies around like brain spotting and just kind of keeping an authentic environment as the social norm, especially in the therapy space or the physical therapy space or whatever kind of clinician that you are. What do therapists and clinicians need to understand about maybe some of the individual accommodations and the more systemic accessibility?
My first thought is how do you process? Understanding how we process information. Because if you think about it, K through 12, we're told how to process information and we're told what's correct and incorrect. So for most people, they've never actually stopped to think about what is my input and what's the output and what are the steps that are going on there. So one thing that I'll say, so I have a little notebook, right? I always have a notebook by me to jot things down. Because I will likely forget and I'll say that in session. So we're told as clinicians in training, you're not supposed to write things down. Well, I tell students that doesn't work for me. And but it's important to have those conversations with clients. So whether that's with and I've been to doctors and I have a great physical therapist and there are times where you might say, okay, let me just jot this down real quick. Let me pause and jot this down. And that might seem so simple, but when we're taught not to do that, that's just one example of saying, because I want to do really well and because this is very important, I want to jot this down real quick. And the way that I explain clinicians in training is, I'll tell clients, these are your notes. So if you're ever curious if it's going to bother you, about what I wrote down, just stop me and say, what'd you jot down? You can always ask. And because I say that, I've never had anyone ask. But half the time it might be just like a symbol or something I need to write down. Or earlier when you mentioned, we need to be aware of what is going on with this, but also understand now's not the time to process it. That's also, I might write down back pain or exhaustion. Like I might jot something down so that I can remember and I can start to come up with patterns of, hey, I don't need to see clients between 1 and 2 o'clock because that's when I hit a dip. And so I've made that accommodation for myself. And I know that's not accessible to everyone in every field or even every counseling setting. But even in my office hours as a professor, I don't have office. I'll have people knock, but it says that it's not, time for people to come in. Because I know I'm not going to be efficient. And I know that likely I'll then become frustrated. And if I push through the whole from 2 to 5, I'm way less effective. So it really impacts my time if I don't have a mental kind of destimulation. But I'm trying to think of other, especially, so lighting is a big piece. I know for a lot of people that I specifically remember in college, I was trying to finish up my psychology degree and I was taking a physics final or something like that. One of those courses that I needed to take, but I would never remember. And I remember I studied really hard for this test and I ended up failing the test because I turned it in early because there was a light bulb. I remember it was to my right. It was one of those, what are those, the cylinders? I can't think of it right now. But those lights that are in those classrooms. Yes, the fluorescent light. Yeah. It was so loud. Something was wrong with it. It was so loud that I remember it felt like the right side of my face was just like melting. And it was physically hurting my ear to a point where like I could not process the information. And so I give those details because people say, oh yeah, the lighting, like, no, like that one was more an auditory thing, but even in my office at Southeastern, I have lamps and I always get comments on it like, oh, this is neat, whatever. But it's because I can't be on a computer and like have fluorescent. I'll just sit there and stare.
Totally.
So, yeah. But it took even like that barrier of, but this is not what professors do. Reminding myself, and I've had many students come in and say like, oh, this is like really helpful. And so for them even to understand you're allowed to do this. Because as a neurodivergent person, we have to explicitly be told you're allowed to. And I know those are very small examples. I'm trying to think of others.
I think that, those are, those are examples that are everyday examples that a lot of people experience. And, even like for the fluorescent lights have like a kind of a visual flickering that's almost invisible to the naked eye. But if you like slow it down on a camera, you can see it. And so that doesn't mean that fluorescent lights are inherently dangerous or bad, but for some of us, we just have a more sensitive system, and that is a part of what contributes to the overload. And yeah, I don't use fluorescent lights anywhere. Like I have to be cleaning something and then it goes on and then it goes off right away. So yeah, these accommodations range from these small little things in the way that we interact and just even allowing for new norms in our clinics, in our clinical spaces is really important. Even like my PT, my physical therapist, like she doesn't have the fluorescent lights on in the room, but it is on in the waiting room that she doesn't have control over. But knowing that that's there, as soon as you walk into that room, there's like an immediate like calming effect. So there are ways to work around it, even when the systemic barriers are still in place, and not always, of course, but I think that's like kind of the main theme or takeaway when we talk about accommodations is you can't control everything, but where you can get some relief, that's really important that we do that.
Absolutely. And what I have found to be honestly the most helpful, and this is again just speaking from my experience, with ADHD, where there's, sometimes I am crippled by the uh pathological demand avoidance or the persistent drive for autonomy with ADHD, whereas, or like I want this new novelty, but then I heard someone on a podcast one time say my ADHD agrees to things that then my autism has to follow through with it. It's like, wait, we didn't agree to this. We didn't discuss this. I was
Yeah.
like, yes, that's exactly what it is. But one of the biggest accommodations that I have made for myself is creating accommodations around expectations. So it might not be that it's an accommodation that ever necessarily gets utilized. For example, on my email signature, it says, I acknowledge you might, that my working hours likely vary from your working hours. Please know that I sent this in a time that's convenient for me. And please know that when you read this, there's no expectation that these are the same working hours as you. So if I need to send an email at midnight, or if I'm working, like, okay, I teach for grad school, I teach till 7:45 some evenings. And most people are, so if I haven't responded to emails, there's that reason, but also just knowing that I have made accommodations around others' expectations, that has really alleviated a lot of the, what I would say is like those symptom diagnoses or those diagnoses that fall within ADHD, autism. So like anxiety or, that feeling of like shame because I didn't do what the neurotypical norm would be. Um, it's me already prefacing it by saying, I might not. And there's the expectation. So I have already said, here's what you can expect of me. And that really has helped me a lot.
All wonderful accommodations. I'm so looking forward to your full presentation at the conference, and I know people are going to get a lot out of it, every clinician that attends this conference. Is there anything else you want to leave people with today as we end here?
Oh gosh. Okay. The not to be cheesy, but I just think of the quote, an inclusive space for one is an inclusive space for all. And I think if we can just implement that in every space, that it benefits all of us.
I completely agree. Thank you so much, Heather. Thanks for listening. If you learned something new today, consider writing it down in your phone notes or journal and make that new neural pathway light up. Better yet, I'd love to hear from you. Send me a DM on Instagram, email me, or leave a voice memo for us to play on the next show. The way you summarize your takeaways can be the perfect little soundbite that someone else might need. And lastly, leaving a review really helps others find this podcast, so please do if you found this episode helpful. And P.S., clicking subscribe ensures you'll be here for the next episode. See you then.